Hello, I'm Dee Eaton, Senior Clinical Editor at Nursing Times. Welcome all. It's a pleasure to be here again chairing the second webinar of the Nursing Times Clinical Skills event series. And welcome Dr. Andrew Ranteld, Urogynecology Nurse Consultant at King's College and Senior Lecturer in Pelvic Health at Brunel University. Today, Andrew will present on urinary catheterisation assessment skills and national recommendations on inserting and removing catheters. At the end of the presentation, Angie will take questions from the audience, so I suggest you note any questions you may have for her during the session. So now, Angie, it's over to you.
Thank you very much. It's a pleasure to join you today for this clinical skills webinar. And what I'm hopefully going to cover over the next half an hour to 40 minutes is to get a better understanding of what is a normal bladder function. We're going to review terminology for lower urinary tract symptoms, and we're going to consider what a basic continence assessment should entail. As part of that, we'll look to understand how to assess when catheterisation is an appropriate procedure to undertake, and then to recognise when is the soonest that catheter can be removed. And we're going to look at that in line with national recommendations and local policies. So let's start with the basics, back to our anatomy. When we think about men and women, urine is produced in the kidneys and where it travels down the ureters into the bladder, where it is stored until a point where it is socially convenient to be emptied from the bladder via the urethra. In women, the urethra is very short, only 3 to 5 centimetres. But in men, we have the additional complexity of the prostate to negotiate through and a far longer urethra, often 15 to 20 centimetres. But the process of emptying the bladder and passing urine is far more complex because it all is controlled through the brain, through the nervous system within the pelvis, so the hypogastric nerve, the pelvic nerve, the pudendal nerve, and through the spinal cord. So what we know for women is as the bladder starts to fill up, the stretch receptors within the bladder send messages through the spine up to the pontine micturition center in the brain that sends your messages back down to the pelvic floor muscles and the urethral sphincter to keep them contracted so that they can hold the urine in. Once your bladder is at a point where it is full and it is convenient, the pelvic floor muscles relax, the urethral sphincter relaxes, and the bladder detrusor muscle contracts, and that then allows emptying of urine out through the urethra. So what is normal bladder function? When we're thinking about what's normal, we should empty our bladder, but we don't always empty it completely. So a residual urine of less than about 50 mils. The first desire to pass urine is around 150 to 200 mils. And a normal bladder capacity is somewhere between 400 to 600 mils. And there are variations between men and women. As the bladder is filling, there should be very little pressure change and pressure rise within the bladder, and there should be no contractions of the detrusor muscle during filling. In a normal system, there should not be any leakage of urine as the bladder is filling, and there should be no pain associated with the bladder filling or the bladder emptying. In general, it's normal to void approximately 8 times during the day and once at night, unless you are a much older adult over the age of 75, when it's actually normal to pee more often at night because our kidneys are working far harder because we produce less antidiuretic hormone, so we produce an increased urine volume at night, so have to pee more often. So let's think about common lower urinary tract symptoms. And when we think about symptoms, we tend to split them into 3 different symptoms: voiding symptoms, storage symptoms, and post-micturition symptoms. So our voiding symptoms relate to problems associated with the actual initiation or the flow. So it could be that it's a slow stream, that it's spraying as it's coming through. It could be that it's intermittent, so a stop-start flow, a hesitancy where it takes a while and you really have to concentrate before the flow begins, or you have to strain to be able to empty your bladder. It could be something that you can only empty your bladder in certain positions, so what we call position-dependent micturition. It could be pain or discomfort as the urine is coming out, so dysuria, or an incomplete emptying of the bladder, so some degree of urinary retention. When we look at storage symptoms, we're thinking about daytime frequency, nocturia, which is getting up multiple times overnight to pass urine, and it has to have been preceded by and followed by sleep. Could have urgency, which is a sudden compelling desire to rush to the toilet, or what we often call an overactive bladder syndrome, which is urinary urgency with or without frequency, usually with or without urinary incontinence as well. And finally, we have the post-micturition symptoms, so either a feeling of incomplete bladder emptying or leakage of urine as you're walking away from the toilet. Within that, we also have urinary incontinence, and urinary incontinence is a very broad term that is basically defined as the complaint of any involuntary loss of urine. But there are many different types of urinary incontinence. We have stress incontinence, which is where you leak with an increase in intra-abdominal pressure, so when you cough and sneeze or jump. Urgency urinary incontinence, where you leak is associated with this sudden desire and you can't get to the toilet in time. Mixed incontinence is a combination of stress and urgency. Nocturnal enuresis is where you wet the bed at night without realizing. Incontinence association with chronic retention of urine is what we used to call overflow incontinence. So when the bladder's already full and we're leaking over. Functional incontinence is when actually people have good bladder capacity, they can hold, but it physically takes such effort and time to get to the toilet, they can't get there before it comes away. Coital incontinence during sex. And unconscious incontinence is when people leak and they can't attribute it to any trigger. And we know that the prevalence of incontinence varies widely, but up to 46% of adults report some degree of urinary incontinence. It is far more common in women than it is in men, but it does become increasingly common in men in later life, particularly for those that may have had issues with their prostate and have had prostatectomies. So what do we do for them? The first important thing that you should be doing for all patients is a symptom assessment. You want to know what symptoms they're reporting and what impact is it having on their quality of life. If it's a patient as an inpatient in hospital, is this a new symptom? Is this something that's been going on for some time? And how much is it bothering them? We need to have a basic understanding of their previous history, their medical history, their surgical history. For the women, we need to know about their obstetric history, and we also need to know about neurological histories because neurological problems have a significant impact on the bladder. We use tools to help us understand, so we may use questionnaires to assess, frequency volume charts. What we would use for patients that are having intravenous fluids, anything that you're looking at part of your normal nursing assessment tools can be helped to understand a fluid intake and the number of times someone is voiding and the volume that they're voiding. Often, we actually need to think about the physical environment and the ability of the patient. For some people, particularly for those that are frail or those that have had surgeries, it's then that they don't have the dexterity to get their clothing off in time, or they're unable to get out of the bed space with their multiple IV attachments that are plugged in at the wall or their different attachments to get to the toilet. A challenge for all patients that may have some form of incontinence is with regards to skin condition, because having constant wetness underneath or wearing pads all the time can cause an incontinence associated dermatitis, but it can also lead to breakdown of the skin. So we need to be able to assess skin condition all around the perineal areas in men and women. When we think about examinations and assessments, we should be looking at abdominal examinations to try to look for bloating. We're looking at vaginal examinations to rule out significant pelvic organ prolapse or problems associated with menopause. It may be a rectal examination to rule out fecal impaction or enlarged prostates. And understandably, many people on a general ward setting don't feel comfortable doing the specialist examinations, but it's then identifying that this needs to be done and referring to an appropriately trained professional. We also need to think about the impact of other comorbidities and medications on the bladder, and I'm going to talk a little bit more about those in a moment. For many patients with lower urinary tract symptoms, an assessment of a urinalysis is really useful to try to understand if there's any underlying infection or other problems that may be useful. But actually, we have to be careful with urinalysis because it can give us a lot of false results, particularly in women over the age of 65. So it's about making sure we're using the right test in the right person. And sometimes sending urine for a midstream urine is a better option. And one of the most important things that we need to do is an assessment of post-void residual, because that allows us to assess how the bladder is emptying and decide. That then helps us decide on what other management is appropriate. Other things that you need to be thinking about within this initial assessment of patients is their mental state, their cognitive state, their ability to be able to toilet themselves, or if they are unable to toilet themselves, what level of assessment that they need or what level of prompting they need to go to the toilet. We need to think about the facilities that they have available to them in the hospital setting that they're in, but also within their area at home if they're going to, when they're going to be discharged and they have issues. And we need to think about what incontinence aids and equipment they may have been using before they came into hospital and what they're going to be using in hospital and if that's going to be carried on in the community afterwards as well. So there are many different comorbidities that can impact upon bladder function. And it's often because it either has a direct impact either on the neurological side of things, so in the nervous communication in the spinal pathways, such as those that have had a stroke, Parkinson's disease, hydrocephalus, or it can be other diseases, so diabetes can impact the bladder, joint disease or COPD affect the ability to mobilize to the toilet. Congestive heart failure often causes a diuresis or peripheral edema that then increases nocturia. Those with sleep apnea have significantly more bladder problems, particularly of a night time, because when you have sleep apnea, you produce certain proteins that enhance your urine production overnight. But we also know issues around impaired cognition, mobility, inaccessible toilets, and lack of toileting assistance are huge factors that impact upon this. There are also a major number of drugs that all impact upon the bladder. Now, I'm sure on all of you that have been doing drugs round for your patients, you'll have seen patients on ACE inhibitors, calcium channel blockers, diuretics, lithium, opioid analgesics for pain relief post-surgery, antipsychotics, and all of these can impact on the bladder function and either cause urinary incontinence, overactive bladder symptoms, and urinary retention. So you need to look at the medications that they're on. Now, as a first line, for every patient with the post-void residual, we should be looking at bladder scanning. And actually, one of the first clinical skills that you should be learning with regards to your bladder assessment is how to perform a post-void residual using a bladder scanner, because bladder scanners prevent unnecessary catheterizations if the residuals are not high. But also for patients that may have catheters that you're worried that they're not draining, they're blocked, by using a bladder scanner to assess if the bladder is empty, can avoid unnecessary catheter changes, reducing risk associated with catheterization. But one of the first things that we should be doing for all patients is promoting continence rather than trying to manage symptoms. We need to offer regular toileting to our patients. You know, if they're not able to get to the toilet themselves, they will become incontinent or they will have issues with retention. So we should be offering regular toileting opportunities, and it is normal to pee about every 3 hours. However, if you haven't assessed your patient to know what was normal for them before they came into hospital, how do you know how often to offer it? We need to challenge the routines that are offered within a hospital setting. For us, on a normal day, for most people, when they wake up in the morning, the first thing they would do would be go to the toilet and empty the bladder. Now, if when our patients are first waking up or we're waking them up to do the set of observations, if we're not taking that opportunity to help them, assist them to the toilet to empty their bladder, again, we may be promoting incontinence or withholding of urine rather than good bladder habits. So with every assessment, we need to be looking at what is the normal baseline for the patient and trying to set a care plan in place that meets their normal needs. Within that, it's also about toileting position. We know that there are positions which are the most appropriate in which to empty the bladder and bowel. It's called the perfect poo position, and it's about sitting on a toilet and having your feet comfortably resting on an area so that your knees are higher than your hips, bending forward with your elbows on the knees. And in many cases in the hospital settings, if people are put on commodes or onto bedpans or things, it's very difficult to be able to empty appropriately. So positioning is a big thing that you need to consider. There is a minimum standard for continence care in the UK that was developed by the UK Continence Society, and that was approved by all of the national associations. And they actually set a competency for a minimum standard of continence assessment that is applicable to all healthcare professionals in the UK. And the minimum competency that has to be achieved is the ability to take a basic history about continence status from the patient, to assess symptom bother and the desire for treatment, to be able to do an examination of the perineum to identify any excoriation, and to be able to undertake a functional assessment of mobility, manual dexterity, and environment to ensure safe toileting or to identify additional care needs. But actually, one of the biggest challenges, particularly in surgical wards within hospitals, tends to be around issues associated with urinary retention, because this is an incredibly common post-operative complication that is caused when patients come into hospital for their routine surgery. So when we think about urinary retention, it's basically defined as the inability to pass urine despite persistent effort. And there are a couple of different types. You have acute urinary retention, which is a painful, palpable or percussible bladder when the patient is unable to pass any urine when the bladder is full. And you have a chronic urinary retention, which is generally not painful, but there is a chronic high post-void residual. And this is most commonly seen in men with protostatic enlargement. There's also the term of voiding dysfunction, which is an abnormally slow or incomplete emptying of the bladder. So what are the risks? We know that post-operative urinary retention is incredibly common within a hospital setting, and there are many different risk factors. Men are more likely to have post-operative retention than women. If you're over 50, it's an increased risk. Anybody or any woman having gynecological surgery or previous pelvic surgery is an increased risk. If you're having a colorectal surgery, a hernia repair, an orthopedic surgery, there's an increased risk. If you have a background history of prostate enlargement, neurological disease or diabetes, you're at an increased risk. And the use of certain medications preoperatively or intraoperatively also increase the risk. We know there are intraoperative factors as well. So those that have IV infusions of greater than 750 mils during their surgery, those that have a prolonged surgery, or those having spinal or epidural anaesthetics are an increased risk. And this one's particularly important for women having babies. So for women having caesarean sections or some sort of operative vaginal delivery, there's a significant retention rate post-epidural. We also know that any patients having sedative medications such as vidabilam, or those having a patient-controlled epidural anaesthesia or a PCA pump, increases the risk of urinary retention. But we have to be careful to strike a balance, because as much as the fact that we know, yes, the anaesthetic agents all have an impact on causing retention, increased pain and being in a significant level of pain increases the sympathetic activity, and ineffective pain management increases the tone at the internal sphincter. So if your sphincter tightens and becomes increasingly tight, it increases the risk of urinary retention because it needs to be able to relax, to empty. We also know that the anaesthetic agent use have a significant impact. So general anaesthetic agents and the opiate analgesics used cause the bladder to become atonic because it interferes with the autonomic nervous system. But we also know that any of the spinal analgesics and the spinal anaesthetics, they enter the cerebral spinal fluid and travel to the brain. And then they have a central effect on the pontine micturition center, which is the area in the brain that I spoke to you about earlier that controls the connections between the bladder and brain to allow the appropriate relaxation and contraction mechanisms to be able to empty. But as well as the medications and the surgical risks, there are very simple, basic nursing skills that also have a significant impact on urinary retention. The ability to have a call bell in close proximity, the proximity to the toilet to get to, the ability to have some privacy, being in a 4-bedded bay when you're trying to pee into a bedpan or onto a commode, often psychologically inhibits people's ability to relax and empty their bladder. You know, restriction of movement by infusions, dressings, drains. The time of day has a huge impact because that then impacts on the availability of staffing and how busy. I know sort of on the wards we're busy at all times, but there are times when there may be more staff around versus times there will be fewer staff to assist in reducing the environmental factors that inhibit appropriate bladder emptying and toileting. So we've gone through some of the background, the terminology, the common things we may see. Now let's think specifically about what you need to know and be aware of before you're going to undertake catheterization. Now, the minimum standards that I spoke to you about earlier do have a competency document to help, but all the bits that I'm going to take you through next actually come from the RCN Catheter Care Guideline that was updated in 2021. And this is a document that's really useful to go through and gives you a lot of the background and is easily available to download from the RCN website. So the guideline sets out different areas of catheter care that need to be known about. So suprapubic catheterization, trial without catheter, intermittent catheterization, catheter reviews, education, maintenance, infection control and care, and catheter guidelines for the end of life. And I'm not going to go into any detail about any of them, because actually what's important in the initial stages are the things that you need to be aware about prior to undertaking catheterization. So actually what I'm going to focus on is what you need to know and be aware of with regards to legislation and policy, competence, documentation, anatomy, physiology, consent, decisions influencing catheterization, risk assessment, and catheter-related equipment. So let's think about anatomy and physiology. I've given you a very brief overview of certain things, but actually that is not the full amount of things you need to know. You need to know the anatomy and physiology of male and female lower urinary tract in relation to function and status, including urine production and what influences, what is normal, the impact of the nervous system, including autonomic dysreflexia in those with spinal cord injuries. You need to know about the bowels and its link to voiding problems, the endocrine system, impact of catheter usage on sexual function, the prostate gland, your sphincters, the urethra, how voiding dysfunction is a problem and how a catheter can be used to relieve it, the anatomy and physiology links to common catheter-related problems, and how to educate and advise individuals in the use of catheters, particularly on anatomy, function and sensation. And these are all as set out in the Skills for Health document that is available nationally. When it comes to legislation and policy, you need to know legislation, policy and good practice, not only from your local hospital or your local care group, setting out what to do, but you also need to know where that's come from. What are the international, European, UK national legislations about this? What procedures can affect your work practice and how do you use those in relation to care? So it may be that we're looking at talking about NICE guidelines. We may be talking about national practices with regards to aseptic non-touch technique, infection control. All of these are available within the National Occupation Standards and are all set out within the catheter care document to look for further information. When it comes to competence, it's not only competence in the ability to perform the task of catheterization, it's about the competence in understanding the infection control issues around it, the products and the catheter formulary that you have in your local area, what devices you're going to use and how to maintain that catheter safely. But it's also about knowing the importance of working within your own competence and when to seek advice if faced with situations that you don't feel you have the skills or the competence to deal with, in line with NMC guidelines, Skills for Health and National Occupational Standards. Every catheterization that is performed, consent should be appropriately sought for it, except for in emergency situations when the patient is unable to provide consent, such as in traumas in the middle of emergency surgeries. But for any patient that we are looking to go and perform catheterization, they must provide valid consent before the procedure is given, and that should be documented in line with your local policies. And for those that are unable to provide informed consent, then you have to follow your local policies for those individuals. Documentation is also a huge part of this. You need to document why catheters are being inserted and what it's there for. So your records need to clearly, accurately and correctly provide relevant information in ongoing patient or personal urinary catheter care records. You need to understand all your information governance rules, your data protection rules in line with your local hospital training, and make sure that you perform in line with your local regulations. But actually, more specifically, when it comes to catheter care, the documentation is important because you need to document insertion, removal, daily assessment of catheter, indications for use. You need to report if there are any catheter-associated UTI symptoms, what drainage symptoms are being used, how is the catheter being secured, what sort of catheter passport are you using? And that's predominantly more on patients being discharged with a catheter. But all individual trusts will have their own documentation system or reporting form for catheter associated information. So you need to be aware of what the local requirements are. But the biggest thing is coming into is in your risk assessment, because we know that using any form of catheter has risks associated with it. You can develop a catheter associated urinary tract infection that can lead to sepsis. But again, long-term catheterization can also cause damage to the bladder, to the urethra, and in the long term affect lower urinary tract function. So you need to understand the different risks and health issues that will influence how, where, and when to catheterize, and when to remove that catheter and undertake a trial without catheter. You need to know the risks associated with catheterization and how to minimize the impact. You need to look to determine whether a patient still requires a catheter, and when an alternative such as intermittent catheterization is appropriate. And to be able to do that, you need to know how to assess and reassess individuals' health status as part of a multidisciplinary assessment. So let's think about indications for catheterization. And within this, I'm talking about long-term and short-term urethral indwelling catheterization, suprapubic indwelling catheterization, and intermittent catheterization, because these are all different options that have advantages and disadvantages in each situation. And that's something that you need to be aware of within your knowledge base. But ultimately, there are three scenarios when we're going to be thinking about indications for catheterization. The first is related to bladder drainage. So we know for those having selected surgical procedures or the need for interruptive monitoring of output. It may be those during or post-surgery for a variety of different reasons. It may be because someone's had a significant injury to the bladder or the urinary tract. It's used in conjunction with an epidural anaesthetic or certain anaesthetics. We may be using it as a management strategy for those with acute or a chronic urinary retention, for people with a critical illness that requires accurate measurement of urine output, particularly those that have abnormal renal function tests. We would use a catheter for monitoring. For patients on an end-of-life pathway to promote comfort, these are often used, but this is assessed on an individual basis. And in very rare cases, we would use catheterization for those with intractable incontinence or neurogenic bladders, but this is a last resort, and these would generally be patients that have gone through multiple specialist services, assessments, and other treatment management plans. They're not your standard patients that would be being admitted to the ward with a new onset problem. We also need to use catheters to do investigations. So if we're looking to assess a residual volume of urine, we sometimes might use an in and out catheter. Now, ideally, in all situations, a bladder scanner should be used when appropriate. But in some emergency situations, bladder scanners aren't appropriate, or if people aren't appropriately trained, or in certain situations, scanners aren't accurate. For women that have large ovarian cysts, or for those that have big abdominal ascites, they're measuring the volume of fluid within the pelvis rather than in the bladder. Or for those that have had significant suprapubic trauma and you can't apply pressure in that area, we would use an in and out catheter. We also use catheters to perform bladder function tests to assess lower urinary tract symptoms, and in very select cases, to be able to obtain a sterile urine specimen. And finally, we'd use them for treatment, for the installation of drugs such as chemotherapy, to assist in the healing of open sacral perineal wounds, for those with prolonged immobilization, and for those for continuous bladder irrigation or lavage such as clot retention. But it's always important to consider for males, when the indication's more wound healing and we know that they are emptying their bladder, a condom, catheter or urinary sheath should always be used as an appropriate if they are able to empty their bladder. Our biggest concern is around catheter-associated urinary tract infections. And we know these come from sort of the colonic or the perineal flora of patients, comes from the bacteria on the hands of the staff, the carers, their patients. And we know the microbes enter the bladder on the outside of the catheter surface and on the inside of the catheter surface. And for every day that that catheter remains in situ, there is a daily risk of bacteriuria of 3 to 10%. And by day 30 of catheterization, 100% of patients will have bacteriuria. There are many risk factors for colties. The insertion technique, their technique to maintain and care for the catheter, those that have had previous catheter use, long length of stay in hospital, the location of where the catheter was inserted. So there is a difference between those having it inserted on the wards versus emergency departments versus theatres. Women are far more prone to it because we have a much shorter urethra and have an increased risk of infection. The older you are, the more likely you are to develop one, and those with impaired immunity or general debilitation. And it's about the education that we can do to prevent this. And the common thing is, to prevent a catheter-associated urinary tract infection, then you should have no catheter. But actually, there are many times when a catheter is the appropriate intervention. So rather than not putting a catheter in for appropriate indications, it's about making sure we are removing the catheter in good time. We want to rule out inappropriate indications for catheterization as well, and that should be the first stage. But for appropriate catheterizations, our next step is to remove the catheter as soon as possible. So we have the Houdini principle or protocol that's been introduced in most hospitals to look at daily indications for catheter. So if there's hematuria, obstruction, a recent urological surgery, if the patient's hemodynamically unstable, a neurogenic bladder dysfunction, then we don't do a nurse-initiated trial without catheter. We wait until there is an appropriate decision from a healthcare professional. However, if you cannot answer yes to any of these and you are unable to find a continued indication, we should be looking to undertake a trial without catheter. But until you can undertake a trial without catheter, you need to make sure that you are conversant with appropriate device management. So you need to be aware of hand hygiene, antisepsis, device securement, your non-touch technique, how you're dating things when you're changing the equipment, making sure you have the right equipment, and how you're documenting this. And this leads very nicely into the education that we should providing our patients and their carers. You know, our patients should be pulling us up if they don't see us clean their hands before we're touching their catheters. We need to avoid disconnecting catheter tubes and drainage bags. We need to make sure catheters are secured, they're not kinked, that the bags are below the level of the bladder to prevent backflow and ease drainage, and to make sure that the bags are being emptied regularly and that nothing stored at the spout's not touching anything whilst being emptied. And that's where we need to understand our catheter-related equipment. Now, catheter-related equipment covers lots of different things because it also needs to cover the choice of catheter that you use in the first place, such as ensuring that any catheterization that happens in a male patient happens with a standard length catheter, and a female or shorter catheter is never inserted into a gentleman. That is classed as a never event. But we also want to make sure that you're using an appropriate catheter because some are short term, some are long term. Some are licensed for 7 days, some 28 days, some 90 days. Different equipment is available in different hospitals. So it's about knowing what your local formulary provide and then what the appropriate equipment is for that patient at that time. So when we're just thinking more about the final policies that you should know of in your own individual trust or area, there should be a catheterization policy and a local competency document that you should follow and have had signed off by an appropriately trained supervisor. You need to know your infection control policy and your no-touch technique policy. You need to be aware of your continence formulary, your hospital guidelines with regards to obtaining valid consent, how you should be informing your patient and how to appropriately document it, or what you do when a patient is not able to give informed consent. You need to know about your trial without catheter protocols. But before all of this, what you really need to know about is your hospital continence assessment and care plans to prevent catheterization and the need for catheterization in the first place. Now, there are a couple of very useful resources that you can use. So like I said, you've got this catheter care guideline from the RCN that's really useful. NHS England website have a whole section on urinary catheter tools. And there's also Health Education England have an e-learning module on continence and catheter care that is available for all of those working in healthcare in the UK. So at that point, I'm going to say thank you very much, and I look forward to taking your questions.